Welcome to the show Talk with Your Doc, and with me is Dr. Kenneth Gehman. We are talking today about lung cancer. Dr. Gehman, we just talked about various risk factors, various investigations to diagnose the lung cancer at the earlier stage, and you mentioned that once you have a CT scan and to confirm that there is a lesion, you do a biopsy, and biopsy comes back to us, and we diagnose the biopsy either as a cancer or not, and if it is a cancer, it is a small cell carcinoma or non-small cell carcinoma, and 80 to 90% are the non-small cell carcinomas of the lung, which are most commonly adenocarcinomas or squamous cell carcinoma. So once the patient gets diagnosed with, say, non-small cell carcinomas, what sort of investigations you order further?
Well, the two investigations that we usually get next are what we call a PET CT scan. The other is, obviously we want some breathing tests to know how good or bad someone's breathing is because of all the damage from cigarettes over the years. PET scan is the most sensitive test to tell us about...
What does the PET scan do?
So a PET scan, it involves the injection of a specially labeled form of sugar when we know that cancer cells metabolize sugar.
Yes.
And take up this marker and therefore light up on a PET scan.
Right.
So it's the most sensitive test to tell us about spread elsewhere in the body and also about spread to the lymph nodes in the central part of the chest.
So with the PET scan you can decide the staging of the disease probably.
Yeah,
what stage is the cancer?
PET scan will, often it can tell us, for example, that there's been spread to the liver or spread to the lymph nodes in the central part of the chest, tell us that the cancer is locally advanced, and that surgery, for example, will not be reasonable.
So depending on the stage, what is the survival of the patient? Like say stage 1, 2, 3, 4 in the lung cancer at this time, day of age?
So stage 1, which means basically the disease is limited to the lung, as at best somewhere around 50%. Once you have spread to regional lymph nodes within the lung, that's the survival is about 35%.
35% when you say 5 years, patient will survive. 35% of the patient will survive for 5 years. Probably.
That's correct. Right. And then stage 3, which is usually spread to the lymph nodes in the central part of the chest, is between 15 to 25%, and if you have spread elsewhere in the body, it's essentially 1% or really no chance of cure.
Right. So lung cancer is a very lethal disease, and many of the patients has.
And unfortunately, because of the fact that we don't have screening, many patients present late. 50% of the people that we see on initial presentation will have stage 4 or disease which is spread elsewhere in the body and is incurable.
Wow. So once the staging is done with this and patient has various treatment options nowadays available like surgery, chemotherapy, radiation. So how does a patient make a choice?
Well, it depends really on the stage of the disease. If we are dealing with early stage disease which is limited to the lung, then treatment of choice is usually surgery. Surgery has the maximum chance of curing someone of their disease, but you have to be fit enough to tolerate surgery.
So early stage cancer can be cured with the surgery?
Absolutely, can be cured with surgery. The second choice for early disease is radiotherapy. Radiotherapy also offers a good prospect of cure, not usually as good as surgery, but some patients cannot tolerate surgery.
So patient who does not want to go for surgery, but that is an early stage, then they can go for radiation as a treatment?
That is correct.
But that can cure the disease?
Yes.
Radiation by itself can cure the disease?
Yes, absolutely.
Right. Now in the surgery also there are various options like whole lung has been removed called as pneumonectomy, or part of the lung, lobectomy, wedge resection. So can you please explain what is the lifestyle after removal of the entire, say, lung is removed?
Well, this really depends on the individual's lung function. We are all built with a lot of redundancy in our lung function. So if you've never been a smoker, I could remove 1.5 of your lungs,
and then I can survive?
and you can survive. You may not be able to run a marathon, but you can still do the usual activities of daily.
Half the lung out of 2.
Yes, but if you've been a smoker
then
for many years, we need to know how good or bad your lung function is.
Right.
So we need some breathing tests to establish that.
Right.
I have many patients who we do our standard operation, which is a lobectomy, and they live, useful, productive lives. Yes, admittedly, if they really exert themselves, they're going to get out of breath sooner than they used to.
Right. So with this whole lung removal or part of the lung removal, are there any complications with the surgery?
Oh, absolutely. I think the number one thing we get worried about is death from surgery. Lobectomy, chance of someone dying is 1.8%.
That's very low.
Which is pretty reasonable.
Yeah.
Pneumonectomy, or taking out the whole lung, risk of mortality is between 5 to 7%. Right. It's a much bigger operation. Right. Our gold standard procedure is a lobectomy, because no one has ever shown that taking out the whole lung is a better operation than a lobectomy if you can completely remove the cancer in that fashion.
Now, following surgery, one may undergo radiation or chemo, and we have heard about the new treatment, targeted therapies. So can you please tell us about the new targeted therapies and how does it affect the prognosis of the patient?
So what we have learned about some lung cancers is that they have mutations in the tumor, and we now, and the two classic ones are EGFR and ALK.
Yes.
Unfortunately, only about 15% of lung cancer actually have these mutations, and now we have special drugs which we can target those mutations at. Okay, so historically, if we had someone with locally advanced lung cancer, not amenable to surgery, and gave them chemotherapy, well, they might get a year. Okay, if you have these mutations and you get these special targeted oral agents, then I have patients who are doing well 2 or 3 years out. It's a huge improvement in their care. Right. But unfortunately, only 15% of patients have these mutations. Tends to be people who have not been significant smokers, and more common in Asians.
Right. Okay. So once you send the biopsy to us, we also do this EGFR and ALK testing as a pathologist, and once those are positive and we send you the result that okay, EGFR is positive, then you treat them with this targeted therapy.
Yes, so in patients with advanced disease, then they would see a medical oncologist and discuss the option of targeted therapy versus traditional chemotherapy.
Is there any complication with the targeted therapy?
Well, targeted therapies depends on the drug, but they can have side effects. Tarceva is the classic drug, and it can cause issues with skin rashes is the classic side effect, but very well tolerated and huge benefit to the patient.
Right. And is this targeted therapy reserved for the late stage disease, or early stage disease also can have the targeted
Well, we don't have evidence that using that therapy when you have other modalities for local care make a difference. So if you have an early stage cancer and it's EGFR positive, we would not treat them if they've had curative therapy. Yes. We reserve that for if your disease should come back, then we use that therapy to try and keep things under control.
That's good. So patients have a variety of choice depending upon the stage of the disease and how much is the disease spread all over the body, and depending upon that, with the help of a surgeon, the oncologist, radiation oncologist, they can decide the various course of treatment.
Absolutely.
Yeah. Thank you, Dr. Gehman. Thank you so much for coming today and helping us to know a lot of information about lung cancer.
It's been a pleasure.
Really appreciate it. Thank you. Thank you, everyone. So next time we are going to talk about the breast cancer. Please join us for the next show, Talk with Your Doc. Thank you.